So as Luch mentioned, I am a congenital heart surgeon. However, I've always had an interest in adult congenital heart surgery. And not only at the University of Washington and Seattle Children's have I led the adult congenital heart surgery program, but I also did this in Birmingham at the University of Alabama and Children's of Alabama. And I think the important thing to understand is, the surgery for Marfan syndrome and other connective tissue disorders is mostly an adult surgical specialty. However, there are a handful of teenagers and younger children that we do operate on at the Children's Hospital as well. And so I have a reasonable amount of experience in that. And then also some of the adult congenital cardiologists, like Dr. Buber, do follow patients with connective tissue disorders. And at some centers, those patients are referred to adult congenital surgeons like myself. And so I do have, while I'm not as busy in terms of operating on connective tissue disorders as some of the aortic surgeons at the University of Washington, I do have a good amount of experience in this field, and I'll share with you what I know. Let's see. So first, I want to thank and give credit to Dr. Chris Burke and Dr. Scott DeRue, who are the two aortic surgeons at the University of Washington. I collaborate with them quite a bit, especially when we have complicated aortic patients at the Children's Hospital. And Dr. Burke comes over and operates with me from time to time when we need his assistance, which is a really nice partnership here at Seattle Children's. I also want to acknowledge the vascular surgery team. I don't work with them as much as Dr. Burke and Dr. DeRue do, but we have an excellent team of vascular surgeons, and we'll be hearing from Dr. Shalhoub here soon. And I know that Dr. Burke and Dr. DeRue work with them regularly in patients with connective tissue disorders. So let's talk a little bit about thoracic aortic aneurysms. This is, from a cardiac surgery standpoint, and when we're talking about connective tissue disorders, this is what we always think of. And if you look at the image here in the slide, there are different parts of the thoracic aorta that can develop an aneurysm. Aortic root aneurysm is really the most common that's associated with connective tissue disorders, particularly Marfan syndrome. But all patients with connective tissue disorders can get aneurysms anywhere, and that includes the rest of the ascending aorta, the aortic arch, and the descending aorta. I will say the majority of my talk is going to focus on replacement of the aortic root and ascending aorta. And so there won't be as much certainly about the descending aorta or the arch. 20% of all aneurysms come from a genetic cause of some sort. And those are, like I mentioned, more likely to involve the aortic root or ascending aorta. And then patients that get significant atherosclerosis are those the type that are more likely to develop descending aortic aneurysms. The goal of surgical therapy, anytime we're treating patients with aneurysm, is to prevent an aortic catastrophe. Now, what is an aortic catastrophe, you may ask? This is primarily known as an aortic dissection or a tear in the intima, or the internal layer of the aorta, from the other layers of the aorta. However, it's not just limited to dissection. As a dissection progresses, as you can see in this image, it can lead to rupture of the vessel. It can also tear down into one of the coronary arteries of the heart, leading to a myocardial infarction or a heart attack. And these things are more common in aneurysmal aorta because of the increased wall tension on the larger vessels. Surgical repair is definitely possible in a patient with an aortic dissection. And honestly, anybody with a dissection in the aortic root or the ascending portion of the aorta, that is considered a surgical emergency, and we operate on them right away. The downside to doing this when the aorta tears, however, is that patients are often much less stable, and there's a much higher risk of death and major complications than if we were to repair the aorta or replace it electively and prevent this from happening. Let's just briefly go over some of the more common connective tissue disorders, and some of the other speakers have done this, but as we all know, Marfan syndrome carries a mutation in the fibrillin-1 gene, which is an extracellular matrix protein. The part of the aorta that's most commonly affected in Marfan syndrome is the ascending aorta, aortic root, and the aortic annulus. Loeys-Dietz syndrome is a little bit more aggressive form of a connective tissue disorder. It involves mutations in the TGF-beta 1 and 2 receptors, as well as a number of other genes. Dissections and aneurysms can form and occur at any age with Loeys-Dietz syndrome. And we see this a little more commonly, I would say, in terms of needing aortic intervention in teenagers and children. There are also tortuous arteries and aneurysms that can form throughout the body. Ehlers-Danlos syndrome type 4, or the vascular type of Ehlers-Danlos, is really a pretty rare disorder that we don't operate on particularly commonly. It involves a mutation in type 3 procollagen. And interestingly, it's aggressive enough that there can be spontaneous rupture of even smaller arteries in the body. And dissection can occur in a completely normally sized ascending aorta with this genetic variant. Familial thoracic aortic aneurysm is sort of a catch-all term that includes patients that have a family history of aneurysm or aortic dissection, but none of the above mutations that we've mentioned. There are, however, a number of genes responsible for contractile function of smooth muscle that can lead to aneurysms, as well as other genes involved in the TGF-beta pathway. So who should be referred for surgery? Some of the other speakers have mentioned some of these size criteria, and I'm only speaking about adult criteria in this situation. But patients with Marfan syndrome, once their ascending aorta or aortic root gets above 5 centimeters, that's an indication to refer for surgery. And that's because the risk of dissection at that size really outweighs the risk of having surgery at this point. Now, we will operate on patients with smaller aortas if they also have risk factors. And the risk factors we look for are a family history of aortic dissection, any aortic growth more than 3 millimeters a year consistently, or severe aortic or mitral regurgitation, and then patients that desire pregnancy at that size. Additionally, if someone has a rate of growth more than 5 millimeters a year or symptoms, that could also be an indication for an operation at any size. The symptoms that typically come with an aneurysm include mostly chest pain or chest pain that radiates to the back. With Loeys-Dietz syndrome, now I've seen a couple of different numbers depending on the publication or the guidelines, but we generally operate on patients with smaller aortic roots in Loeys-Dietz syndrome because of the risk of dissection at smaller sizes. This publication mentions anything greater than or equal to 4.4 centimeters. When you measure the aortic root by echo, the recommendation is down to 4.2 centimeters, and mainly that's because you're measuring the internal diameter. But this, again, we do operate at smaller aortic sizes in this group. This is also similar for Ehlers-Danlos type 4. And then there really aren't specific recommendations that I could find for familial thoracic aortic aneurysm. But in general, patients in this group tend to follow the Marfan syndrome guidelines from what I could figure. So what are the surgical options when you get referred for aortic root replacement or ascending aortic replacement? And I think before we talk about them, I want to make sure everybody understands what are we talking about when we talk about the aortic root. And if you look in this image, the aortic root is really everything between these two green circles that have been drawn within the figure. And that includes everything basically from the ventricle of the heart, which is the pumping chamber, all the way to above the aortic valve and above the coronary arteries, which you can see in this image here, are these two small vessels that come off and supply the heart with oxygen. So when we're talking about surgery for connective tissue disorders, we're typically talking about an aortic root replacement plus or minus replacement of part of the or all of the ascending aorta up to the aortic arch. And because the aortic root is such a complex structure involving the aortic valve, the coronary arteries, and the sinuses of Valsalva, which are the part of the aorta below or within the valve that kind of bulge out and allow the blood to flow the way that it does. There are a number of different ways to do it with varying complexity. So in general, when you're talking about a surgical aortic root replacement, there are two main categories. One is the valve sparing approach, where the aortic valve is left in place. And then the other is the valve replacing, or what we call a Bentall procedure, where the aortic valve is taken out along with all the diseased aorta, and the whole thing is replaced with what you can see here. This is a valve that's been sewn on the inside of a long graft that we use to replace the aortic root and the ascending aorta. One thing that you might notice with these pictures is that in both cases, the coronary arteries have to be removed from the native aortic root and then sewn back to the graft. And we try to take as much of the coronary artery tissue as possible, leaving as little as possible that can become aneurysmal in the future. And so in these pictures, you see there's just a tiny bit of aortic tissue left after we've done the aortic root replacement. Now, when you talk about valve sparing options, you can really divide them into two additional camps. And one is the reimplantation procedure that was popularized by Tyrone David out of Toronto. And the other is what you might have heard of called the remodeling procedure, which was popularized by Magda Yacoub in London. And the real difference, and you can see this in the pictures, is that the reimplantation technique takes a tube graft like the one I showed in the previous slide, and it goes completely over the valve and all the way down to the aortic annulus. And the important thing about that is that it prevents the aortic annulus from getting any bigger with time. The remodeling technique does not do that. You sew the graft directly to basically the edges of the valve and leave the aortic annulus basically unprotected. So what are the advantages or disadvantages of both? You probably can guess what I'm going to say based on what I just mentioned in the previous slide, but starting, both are fairly technically challenging operations. But the real big difference, like I mentioned, is what the graft material actually covers. And so if you get a David procedure or the reimplantation procedure, your aortic annulus should be stable and secure for years to come. With the remodeling procedure, your aortic annulus is not supported unless you provide additional support internally. And there are a variety of devices I'm not really going to talk about that can be placed on the inside of the aortic annulus to prevent it from dilating. If the aortic annulus does dilate, the problem with that is it pulls the aortic valve leaflets apart from each other, and it can lead the aortic valve to start leaking and become a problem down the road. So let's look at some pictures just to understand the technique of the reimplantation. This is what we perform typically at the University of Washington Medical Center or at Seattle Children's, because we feel that it is a better long-term solution for valve-sparing aortic root replacement. Now, this first image is just to sort of give you a lay of the land. This is the heart, and from the position that we see it as the surgeon, we stand on the patient's right side, and after the chest is open, we see the aorta here. The head is going to be off to the left, and the feet are kind of off to the upper right-hand corner. And then this is the apex of the heart. This is the pulmonary artery. And then this is the right atrium. This is just a shot of the inside of what the aortic root looks like. So after we've gone on the cardiopulmonary bypass machine and temporarily stopped the heart, we remove all the diseased tissue, basically part of the ascending aorta and all of the aortic root, and we're left with the aortic valve, which is what you can see right here. It's a sort of triangular shaped structure. We're also left with the two coronary arteries that we leave attached to the heart. This reimplantation procedure is started by placing sutures underneath the valve, and this is really important. You can see in this technique, they only use 3. Some people will put sutures all the way around. Some people use 6. There's really no rhyme or reason to it. but you have to have sutures that get below the level of the valve because they eventually go through the graft and pull the graft all the way down to the level below the annulus. As you can see, those 3 sutures go through the bottom of the Dacron graft here. And then sutures are also placed at the top of the 3 commissures of the valve, which is a commissure is basically where the leaflets come together. And the commissures are pulled in the middle of the valve, in the graft, or in the middle of the graft, and then the graft is brought down on top of the aortic root. When you're done, this is what it looks like up in the upper right-hand corner. It always kind of looks like a Mercedes symbol. And you can see the 3 valve leaflets sort of nestled within the graft there. We then run a suture line along the edges of the leaflets all the way around, all 3. And that's really what provides hemostasis or prevents blood from getting out of the repair. We then reimplant the coronary arteries, and it's very important in patients with connective tissue disorders to, at least I feel, to stabilize the area that we sew together with a strip of, I use the patient's own pericardium, which is a tissue layer that's around the heart. And that just provides extra support and hopefully prevents future dilation. This is what it looks like when we're all done. In this particular drawing, the rest of the ascending aorta was normal, and so it was left in place. Just want to briefly talk about when we operate on patients with Loeys-Dietz syndrome, or if I ever were to operate on somebody with Ehlers-Danlos, I would approach it this way as well. It's important to, at a minimum, replace or do what we call a hemiarch replacement. And that is shown here on the picture, where we not only replace the aortic root, but we replace the entire ascending aorta up to the aortic arch, or at least up to the first head vessel, which is the innominate artery right here. And the reason that's important is that the aortas are so fragile in patients with Loeys-Dietz syndrome that we want to remove the part of the aorta that we had our aortic cross clamp on. And that's every patient that gets an open heart operation has a clamp placed on their aorta, kind of where I'm pointing here in the picture, to prevent blood from coming into the field and allowing us to do the operation. But that clamp does result in some damage to any blood vessel. It's minimal if you don't have a connective tissue disorder, but if you do have Loeys-Dietz syndrome, it can leave you with a weak site that could dissect in the near future. We also put what we call an aortic cannula in part of the ascending aorta to provide cardiopulmonary bypass, and we want to remove that as well. And so with Loeys-Dietz, in addition to aortic root replacement, we're often replacing the entire ascending aorta. This does require a brief period of what we call circulatory arrest, where we're only providing perfusion to the brain. And but again, it's brief. It's only about 10 minutes, and we do it with the patients very cold, so the metabolic rate of the brain is very low, and complications are also very low. So what are the short-term outcomes? Most of the large studies come from high-volume centers, and mortality with valve-sparing aortic root replacement is very low, less than 1%. Stroke rate is very low as well, but it's definitely not zero, and also fairly low re-exploration for bleeding or need for pacemaker. So all in all, it's a safe operation, particularly if you go to a high-volume center. But again, this is only for elective repair. And some papers out there include patients that get a valve-sparing aortic root replacement for aortic dissection. And when that happens, the mortality is much higher. Long-term results, there are just a couple of things I want to point out. This is a table from a textbook that I have that sort of outlines some of the bigger series when it comes to valve-sparing aortic root replacement. And not surprisingly, Tyrone David has the biggest series out there with the longest follow-up since he invented the operation, or at least the reimplantation version of it. And you can see, if you just look at freedom from reoperation and freedom from aortic insufficiency, which are the things that as a patient you would want to know, even out at 20 years, 94% of the patients have not needed an operation, and 90% of them don't have significant aortic insufficiency, which to me, that implies this is a very durable operation. I just also want to point out that with the remodeling technique, you can see freedom from reoperation is a little bit lower, about 10% lower at 10 years, but still not so bad. I want to switch gears a little bit now and talk a little bit about personalized external aortic root support, or PEARS or PEARS. I'm not sure how the acronym is pronounced, but I'm going to pronounce it PEARS. This is something that's relatively new in the treatment of aortic root and ascending aortic disease in patients with connective tissue disorders. And I have to disclaim that I've never done this operation, nor do I know anybody in the United States that's ever done this operation. It's really something that's mainly done in Europe, from as far as I know. But the idea behind the operation is that instead of replacing the aortic root and the ascending aorta, what if we were to just cover it with something that could prevent it from dilating? And this is a sort of a mesh that's created. There's basically 3D printed, or it's created on top of a 3D printed model of each patient's CT scan, so that it is exactly the size of their aorta. And it is then wrapped around the disease portion of the aorta. So who are the types of patients that this has been done on? The indications are really similar to what we talked about for aortic root replacement, so I'm not going to repeat them. However, the surgeons in Europe that have done this have adopted it at smaller aortic sizes than we might operate on here in the United States. And part of that is that the goal of the procedure is really to prevent the aorta from getting to a size that is dangerous at all. And so the median size of the aortas in the series I will present a little bit later is lower than we would typically operate on here. Contraindications that the authors have stated would be an aortic root dimension greater than 5.5 centimeters. So this is really only for smaller aortas in general. Moderate aortic stenosis or regurgitation is a relative contraindication. And then extension of the dilation of the aorta beyond the brachiocephalic artery, or that first branch that goes to the head and the arm in the aortic arch, would also be a contraindication. I do have a series of pictures, like I showed for valve-sparing aortic root replacement, to give you an idea of how this procedure is performed as well. And again, this is a view that we often see as the surgeon standing on the right side of the table, with the patient's head at the left, at screen left, and the feet down at screen right. The diseased aorta, you can see, is labeled with the AO. And really the first part of the operation is to dissect the base of the aortic root away from the rest of the heart. And this is an operation that these authors mostly do without cardiopulmonary bypass. So the heart is completely full of blood, it's beating the entire time, and which is somewhat of a scary proposition to those of us that do most aortic root surgery with the heart empty and completely still. You also have to completely encircle the coronary arteries. And this is a picture showing the surgeon getting around the right coronary artery. And that's important because you need to make a measurement basically from the base of the aorta to the right coronary artery, so that you know where to make your opening in the mesh. A similar type of thing is done with the left coronary, which is very hard to access with the heart full and beating. And then once you have your measurements and the aortic root is completely free, the areas that you marked on the mesh are opened up, and an incision is made between the two of them, so that the mesh can simply be wrapped right around the aorta. As you can see in this small picture, the slit for the right coronary artery was measured correctly, and everything is laying nicely. Once you have the mesh on, the mesh is sewn closed, and that in some patients, I'd say about half of the ones in their biggest series, they made the mesh slightly smaller than the actual size of the aorta, so it tightens everything up when they sew it together. And then sort of the last thing that you have to do is just make sure that there's no impingement on the coronary arteries, which is what they're showing here in this last picture. So I wanted to discuss some data about this procedure. This is a review of the first 200 patients that were chosen for this procedure. And again, this was out of 23 centers in Europe, mostly in Great Britain and Belgium, from what I could gather by the institutions from which the authors came. This is over a 15-year experience. However, the majority of the operations were performed between 2017 and 2019. Median follow-up is only 21.2 months. And so, as I showed in some of the valve-sparing aortic root data, their median follow-up is more than 10 years. So it's a slightly different look at a procedure than what we have for valve-sparing aortic root replacement. Again, they enrolled 200 patients, 194 of them completed the PEARS procedure. 5 were converted to a surgical aortic root replacement, and 1 was aborted. There was only 1 death in the entire cohort. Again, I want to show here the surgical indications. The majority of them were for Marfan Syndrome and Loeys-Dietz Syndrome, a few patients with bicuspid aortic valve and aortic root aneurysm. And then most patients, and this is a little different than if you look at some of the series with valve-sparing aortic root replacement, the majority had no aortic insufficiency whatsoever. 65% had 0. 8% had something that they call 0.5, which is trace, I would guess, and then the majority of the rest of them had mild regurgitation. So starting with a pretty good aortic valve. There is a very low perioperative mortality for this procedure. As I mentioned, only 1 patient passed away. However, there is a pretty high rate of coronary ischemia and/or injury. And I have to think that this is related to having to dissect out the aortic root with the heart full and beating. As I mentioned, this is something I've never done, but imagining trying to get around the left coronary artery with the heart full and beating as a surgeon is somewhat, makes me somewhat queasy, I have to say. You can see here that 11 patients had an intervention for ischemia or coronary injury, which is 5.5% of the group. A number of them had coronary artery bypass grafting. One patient even had to go on ECMO temporarily, and 5 patients had a myocardial infarction. So not a perfect procedure, but definitely a different look at something. Survival is really pretty good with this procedure. And again, most of their operations have been done in the last few years. And so we really only have short-term survival, but even those that had the procedure done 10, 15 years ago have done relatively well. And then this graph here on the right-hand side of the screen is confusing, I'll admit. But basically what it shows is that some, if not all, the patients had a reasonable improvement in the small amount of aortic regurgitation that they had to start with. Only a couple of patients had aortic regurgitation get worse. So I would just want to say my final thoughts on this procedure that I've never performed before is that the data suggests that it effectively prevents aortic dissection. None of the patients in this series ever had an aortic dissection after having this done. But again, our follow-up is not particularly long. The aortic size is stable over time as well in this group. It is an operation that, if done well, it does not require cardiopulmonary bypass. However, 20% of the patients in that series I just presented did have cardiopulmonary bypass for one reason or another. Coronary artery complications are definitely a concern, and long-term data is lacking. And again, it's going to be a procedure that's going to be hard to compare to valve-sparing aortic root replacement, simply because the criteria for having the 2 procedures are slightly different. And so down the road, I think it's going to be hard to have comparative studies. So as a patient, how would you decide what kind of operation to have? And I just put this simple table together, kind of outlining all the different options. And as a patient, you know, all patients are worried about operative risk. Am I going to survive the operation? Durability, is the operation that I get going to last a long time? And am I going to have to get more operations in the future? And then will I have to take anticoagulation? These are all important questions. And so starting with operative risk and going down really the 4 different operations you can get, I separated bio and mechanical Bentall simply because having a tissue valve in your graft and having a mechanical valve in your graft has some implications on life after surgery. All the operations, I think, are relatively low risk. The one question is, the risk of coronary injury with the PEARS procedure. But even in high volume centers, valve sparing root replacement is a pretty low risk operation. Durability, I would say the only one that has poor durability is the biovental, and that's just because all tissue valves wear out with time, and they wear out particularly quickly in younger patients, which a lot of our patients with connective tissue disorder are. Mechanical valves have good durability, but they're always at risk of thrombosis or endocarditis, and so they're not free completely of risks. Valve sparing root replacement has good durability as well. However, some patients that get a valve sparing root replacement develop aortic insufficiency with time and need another operation in the future. Durability of the PEARS procedure is unknown at this time. The only one that you need anticoagulation with is a mechanical Vental, and that's really, I would say, a significant downside to the mechanical valve over the other options. So again, all reasonably good options, but they all have their pluses and minuses. Thank you very much. I'm happy to answer any questions.
Great, thank you. Thank you so much for that. You can stop sharing so now we can see.
Okay.
I can see you. We'll have to take a couple of questions here, and then we'll try to get Dr. Shalhoub back. What factors allow consideration of an open repair of an abdominal dissection versus a thoracotomy?
Yeah, that's a good question, and honestly, that's an area that we typically don't do at the Children's Hospital, so I'm not the expert to ask. I think the extent of the aneurysm, though, is going to determine how much of an incision or how far down the aorta you're going to have to go to adequately repair a thoracoabdominal aneurysm. And I don't know if Dr. Shalhoub is going to be talking about that at all, but I know that her group and Dr. Burke and Daru do a lot of that thoracoabdominal operations at the university.
Great. Hopefully she can address that. And just for everybody who's on here who has some more specific questions, we did do a whole series of aortic surgery webinars about a year ago. And so there are experts talking for an hour about mitral valve surgery, thoracoabdominal surgery, aortic root surgery, aortic arch surgery. So there's a lot of information on our YouTube channel. So I'm going to point you back there. I'm going to ask you one more question because the other questions are not about surgery. I think this is really about the PEARS surgery. Have there been any studies evaluating leaving the tissue intact and placing the support structure surrounding the aneurysm to prevent rupture? I mean, how much data is there on that?
You're talking about how much the paper that I presented on the PEARS operation is the biggest study out there. And it was published just last year. And, really this has been promoted by this group in England and then also some surgeons in Belgium as well. And I looked, there's not a lot out there other than what they have published. And so I tried to give the biggest series that they have out there. There is an operation that's similar to PEARS in terms of wrapping around tissue called the Florida sleeve operation that they do or that was sort of pioneered in Gainesville. But they don't do it necessarily for connective tissue disorder. It seemed like it was more for bicuspid aortic valve, and so it was a slightly different patient population. But what I showed is really what we know about the PEARS procedure.
Okay. What about one more question? What about the success of revisions? How often do you have to do those, and are they successful? Yeah,
so the one thing that comes up from time to time is if you do a valve sparing aortic root replacement and the patient develops aortic insufficiency down the road, that valve can be replaced very easily. We don't have to replace the graft that we used to replace the aortic tissue. We simply open the graft, cut the valve out, and put either a mechanical or bioprosthetic valve in its place. And so those revisions are successful. Other things that can come up include aneurysms of where the coronary arteries are sewn in. Repairing those can be tricky, but luckily that doesn't happen very often. And then aneurysms can occur anywhere else in the aorta as well.